Welcome to our podcast, Psychiatric Services from Pages to Practice. In this podcast, we highlight new research or columns published this month in the journal Psychiatric Services. I'm Lisa Dixon, editor of Psychiatric Services, and I'm here with podcast editor and my co-host, Josh Berezin. Hi, Josh.
Hi, Lisa.
Today, we're going to discuss an article that gets us thinking about what we know and don't know about involuntary psychiatric hospitalization.
So we're very happy to have Dr. Ned Morris, who's an assistant professor of clinical psychiatry at UCSF, on here to talk about his open forum, taking an evidence-based approach to involuntary psychiatric hospitalization. Dr. Morris, thanks so much for joining us.
Thanks so much for having me.
We always start out the podcast with a question about how people kind of got interested in the particular topic that the paper we're talking about represents. So what was the pathway to this area of interest for you?
I think in a few ways. First, when I was a medical student, and I remember seeing an inpatient psychiatric unit for the first time, it was really jarring to me how we would, literally confine people behind locked doors as part of their medical treatment. And it kind of like broadly made sense to me in terms of people are suicidal or potentially dangerous, or maybe they have to be held briefly for safety purposes. But I kind of wonder, where did those policies come from? Like, how are these developed, right? And the second part was really during my residency training. And again, I would get these questions from patients or families, and it would be about involuntary hospitalization. I often couldn't answer. What were often pretty straightforward, like not super complex. These were like, how often does someone get readmitted? Or if they were going into a civil commitment hearing, like how often does someone prevail in these and get released? And I wouldn't have answers for them. I wouldn't know. And I would try to look that up and it wouldn't exist. That kind of shocked me that, one of the most coercive, controversial, but also like potentially life-saving interventions that we do in medicine, like we really didn't have much information about. And so that really seemed like an important issue that I really wanted to kind of look into more.
So I think you touched on some of this in the paper, but that original question about that you had as a medical student about like how did this evolve? Where did this come from? Have you found an answer that you could now kind of like talk to a family member about and say like, well, actually, this is how we got to where we are?
Yeah, I mean, there's kind of like the academic answer, which I'm sure as you both know, we could talk about for hours about the history of civil commitment in the United States. Sometimes I can get to patients and families, but at least with trainees, we'll often actually not to I work in California, not to be like California centric, but there was a law that was passed in the 60s called the Lanterman-Petra Short Act. And that was, at least many people have looked at or it's even been referred to as the Magna Carta of the mentally ill. It was a really important law passed in the 60s where basically, and I'll sometimes even talk about this with patients and families, as before then is what you often will see in media or magazines about the concerns of like people getting thrown in asylums for decades, right? And there wasn't, really loose oversight. And that law in the 60s introduced really two important things. The first is specific criteria. So like danger to self, danger to others, something called grave disability, which is, kind of the inability to take care of yourself for food, clothing, or shelter. And the second is really firm time limits. So timed checkpoints when somebody's put in the hospital. And that, has been thought to influence practices really across the country. Over the last several decades, there's really often been this kind of very stringent focus, one, on largely dangerousness in the United States, and then two is this kind of timed checkpoint. And what I'll say to patients often in my discussions with them is, on the one hand, these can be really, really important protections, right? Like if I was put in the hospital, I would want to have there to be criteria and time limits, and that makes sense, right? On the other hand, it can be really challenging with the legal things that come up where it often will put doctors and patients kind of in situations where they seem against one another. And so I'll actually talk about what that's like with patients, like, hey, here's what a hearing is going to happen. Here's what goes on, and then here's what might happen after that, and trying to educate them as best you can. And so that's kind of a very brief overview of like decades of far, far more complex issues than I think we can get into right now.
Yeah, for sure. I mean, one of the interesting things is that these are state laws, right, across the country. They're sort of regulated state by state. But whenever I do hear about, I'm most familiar with the laws in New York, but whenever I do hear about cases or just examples from other states, it's always that same kind of like frame that you're talking about there, where it's like danger to self or others and a time frame, and then like a legal process around it too. It seems like everyone has kind of coalesced around the same framework. Well, I don't know everyone, the limited number of states that at least I know about.
And I'd say yes and no to that, right? So yes, absolutely. Most states across the country have now developed like specific criteria, often really focusing on dangerousness and then those time limits. On the other hand, just to play devil's advocate, it's very, very different according to what state you practice in, right? And so I'll have patients who only by having heard this over time or knowing, they'll say, yeah, I was section 12. And only because I went to medical school in Massachusetts do I know that that's kind of part of their practices there. Or a patient will be like, well, yeah, that was my third Baker Act. And you're like, wait, and you Google that and that's in Florida, right? And so even as practicing clinicians, having been in this space for years, you may have no idea what a patient's talking about from Wisconsin, Texas, other places, because it tends to vary so much, even though, yes, as you mentioned, the basic framework is pretty similar.
I think like the background sections to a lot of papers are, and sort of the introductions to our podcast are often like, well, okay, so what do we know about the evidence behind this particular intervention? And it seems like more appropriate here to ask, like, what don't we know about the evidence behind involuntary psychiatric hospitalization?
Yeah, that's a great point. How I might answer that is kind of a complicated, is basically there is a lot of literature on civil commitment. One thing we were very hesitant about writing this paper is we in no way did we want to imply like no one's ever thought about this before. No one's ever, like, there are dozens and dozens of papers that have been written about civil commitment. You can drown yourself in the amount of data and papers that have been written. But, and here's the big but, when you look at most of these papers, they're at very, very specific details. So seclusion, involuntary medications, how often might people win a legal hearing or not? And so it'll go through all of these details. And what you realize over time is that if you take a broader view and kind of step back, the question, does this intervention actually work? Does it prevent suicide or violence? Does it improve people's lives? We really don't have a lot of data on that, right? And so one comparison I might make is it's kind of similar to if for chemotherapy, we had dozens and dozens and dozens of studies about how it affects tumor size, how it has side effects, who can afford to have it, who's selected for chemotherapy, but we didn't know, do people live longer when they get chemotherapy, right? That would be kind of a comparison I might make for the current state of, and there's obviously, as we talk about in the paper, a lot of challenges for civil commitment research, but that I think is the important element, is that someone could go to PubMed right now or Google Scholar or whatever and say, what are they talking about? There's tons of studies on civil commitment, but the problem is the broader questions of, does it actually work long-term? That is something that is really challenging to study and that there's really not a lot of information out there about.
What are some of the challenges behind doing some of the studies that would provide some kind of like evidence base for involuntary hospitalizations? Why are we in this both setting of tons of information about the intervention and not so much about the actual outcomes?
The short answer is that basically civil commitment or involuntary psychiatric hospitalization is a very high stakes situation. And because it's a very high stakes situation, there are a lot of ethical challenges to the research. The medical community is often, like, almost to an obsession, focused on randomized controlled trials. And that's another thing we really, really wanted to be careful with in writing this paper, is not to just say, well, we should have randomized trials for involuntary, like, if that doesn't exist, and we were thinking about, there's kind of those tongue-in-cheek papers you can find about, like, why aren't there randomized trials for parachutes, right? And so there's some interventions that are kind of like obvious, right? So you might look and just say it's obvious. If someone is suicidal and they're saying they're going to kill themselves, you put them, you need to have them in the hospital until that person is better and, can be safely in the community, right? That might seem like an obvious answer. But again, if you take a step back and you actually, if you think at a population level, well, we don't know how many people actually would hurt themselves if they're outside the hospital. And, being locked in a hospital unit can be really traumatic and distressing for people. They might lose their jobs, they're separated from their families, they might lose their housing. Are there situations where people get worse? So that's a really big challenge. And so to answer your question, like, why don't we have these types of studies? If you just think about the logistics, if someone walks into an emergency department and is hallucinating and has command hallucinations to kill someone, can you then send that person into the community and randomize them to go home? That's like a really tricky question, right? If somebody comes in and says, I'm going to hurt myself, and can you randomize that person to go home, right? What IRB is going to approve that? So we explore some of these challenges in the paper. Are there observational studies we can do? We kind of talk about other solutions. There are ways you could think about randomizing, such as to, like, crisis, residential units, or not just send people home, right? Have, like, step down levels of care. But at the end of the day, there's really, really challenging questions if you're going to run these types of big trials of if this were to work long term, when you're dealing with really high stakes incidents like suicide, violence, things like that.
And Lisa, when you, not to put you on the spot, but when you hear about this sort of research challenge, do you have something that comes to mind as, this is very similar to the challenge in studying X, and here's how they kind of dealt with it? Or does this seem more like kind of a unique set of challenges?
I do think there have been alternatives to hospitalization that have been developed and are used. For example, the old Lauren Mosher Soteria House, and I know some colleagues in Israel that are trying to develop some comparable types of settings where there's care and observation and support, but not sort of the extreme, if you will, just taking that position of involuntary hospitalization. And I mean, I guess in answering the question, I do have to acknowledge that there's a difference between hospitalization and involuntary hospitalization. And perhaps we need to understand more about what the source of the involuntariness is, if you will. So in other words, if I can imagine many different types of involuntariness. So let's take the example, and we were discussing this earlier. We know that people of color, probably Black men more than any other group, are disproportionately subjected to involuntary hospitalization and involuntary treatment. I don't have the exact data, but I think that's something that is known. So why might those individuals, I mean, it raises the specter that there's not an objective judgment being made necessarily, right? And also perhaps individuals who don't trust the system, who don't trust the processes, might be extremely reluctant to participate in, and maybe that's something we can do something about.
Do you think that some of the challenges of studying this is that you have these laws that are very neat in some ways, and then all these decisions, like every single one is a subjective decision that's made individually by a clinician who has their own idiosyncrasies in terms of their background, training, viewpoint, understanding of the law, setting, resources, all of these things. So it's biases.
Absolutely. I mean, that's a fundamental aspect of kind of what we're looking at here, right? Of where if there's not evidence, if there's not data, one thing we talk about is we don't even know how often people across the country are placed on these holds, right? Whereas there's pretty clear evidence in a lot of the literature about disproportionate diagnoses of psychotic disorders, right? What racial groups or people are more likely to be subjected to emergent, medications or seclusion practices, right? These are like really important things to think about at hospitals across the country. Some of the most, as Lisa was getting to, coercive things that we're kind of doing to people, right? And how do our own biases affect that, right? And so that's a really important thing where you're totally right. Danger to self, what if somebody says I'm going to hurt myself right now versus I'm going to hurt myself in 7 days versus I'm going to do that in a month. These are often really subjective calls that happen in the emergency department. And so, or elsewhere. And, that's a really important thing to think about. If we have these laws that can, subjectivity becomes quite important when they lead to really, really potentially life-saving, but also potentially really distressing interventions where we're doing involuntary things to people, right? And we included a quote from Paul Applebaum in the article, really adding where another challenge to the research here is it's not just health outcomes, right? We're not just, the chemotherapy comparison is a little unfair because we're not just looking at tumor size and mortality benefit, but also there's these other tangible aspects of freedom, autonomy. How do you measure that in an RCT, right? How voluntariness, as Lisa was getting at, right? Like these are really other challenging notions that are really hard to just measure in a research study, but at the same time are really important to think about. Yeah, how does mistrust, how does bias, social determinants of health, poverty, homelessness, how do those factor in? And those are really profound questions I think we need to think about.
After having looked at all this, if you could maybe not design, but like think of two kinds of studies that would really advance our understanding of whether or not this intervention works or not, kind of on a fundamental level, or how it works or when it works, what would be some things that you think are actually doable, right? You're not going to design a randomized control trial. Sure. So like, what are a couple of things that you think we could actually get at given our current sort of like research framework that we have?
Yeah, we lay out 3 approaches in the paper of how we think, and I'll expand 2 to 3 if that's okay with you, just to add those. We lay out 3 in the paper that I think are really, really important for addressing those questions, right? There's limitations to RCTs, to observational studies, but lots of different research has limitations in different fields, right? And so the first is what we talked about earlier, is literally just generating basic data, right? Like if the state is authorizing us to literally put people on locked units and potentially medicate them against their will, right? That should be tracked, right? That should be, I think, tracked at the state level, where basically how often are these holds being used, how often are people on them, et cetera. The second is kind of to Josh's question earlier, is thinking about long-term outcomes, right? We should be tracking how often are people readmitted, what are their long-term health statuses? And one thing I was thinking about as we wrote this paper is surgeons are often tracked on their complication rates, right? They know quite well often how often they have complications, when they're applying to hospitals, advertise based on that kind of stuff. But as a psychiatrist, I don't know about either of you. I have no idea how many of my patients have been readmitted. I don't know what percentage of them have had adverse outcomes. And how can you be doing one of the most coercive things we do in medicine, locking people against their will, when there's no tracking as to who does that more often than other people, who has better outcomes with their patients? And sure, there's issues about patient populations and where you live and confounding variables. But at the end of the day, why do other medical specialties look at their interventions and long-term outcomes and we don't, right? So I think that's the second part, is thinking about the outcomes. And the last thing I'll just add, the third, to Josh's point about what can we do from like a research standpoint to better understand these practices, is you can take either extreme of like involuntary hospitalization is terrible and awful and evil, or you can take, wow, it's really life-saving and incredible, and this is something we need to do. But I think pretty much everybody in that debate, I can't speak for everyone, but I think most people would agree that, hey, it should be used as a last resort when everything else has failed. And I think most people agree on that. So what is the research we can do to study ways to avoid involuntary hospitalization, right? And there's already, we kind of put in the paper promising research on, psychiatric advance directives, intensive home services. There's other alternatives, as kind of Lisa was mentioning earlier, where I do think, even though it's a contentious debate, both people or both sides can come in the middle and say, yeah, there is a middle path of, I don't think even psychiatrists enjoy putting people, locking them in units or giving them voluntary medications. It's a very distressing experience. And what are ways we can kind of reduce the use where it's not necessary, right?
This brings me back to working on an ACT team, which I know it has its own history, but way back when, in the 90s, when I was a part of a team, it really allowed us to build relationships with people. It allowed the time, the space to go out into the community, to go where people were. This particular program focused on homeless adults with serious mental illness, and that costs money. Those kind of services need to, they won't be available if they're not funded. But I do think that kind of investment can really help. I mean, and maybe we don't have a lot of data on this, but it just seems really to make sense, right? By building relationships with people where they are, you can avoid at least some involuntary hospitalizations.
I absolutely agree, right? There are costs and there are thinking of how we place resources, but in my training, I have worked at places where they were charging something like $10,000 or $20,000 a night on involuntary hospitalization units, right? And so we think about how in medicine, often insurance or whatever will pay for the liver transplant, but won't pay years earlier for the Uber ride for the person to go to the AA meeting, right? And so how we think about what are our priorities, and I absolutely agree what you're mentioning about, ACT, that's an example of potentially avoiding hospitalizations. If I'm in the emergency department and I have somebody who is telling me that they are suicidal, and suddenly their case manager appears and says, this is Mr. Smith. We know him very well. Sometimes this happens when X, Y, and Z happens. We have a van outside. We're taking him to his appointment tomorrow. He has his medication. Oh, I'm like way more likely to discharge that person and keep them out of the hospital than the person who has nowhere to go, has no supports, has the psychiatrist wait list is 6 months, right? I absolutely agree. I think the question is, where do we want to prioritize those resources? And I think that's a great example of looking upstream to kind of avoid these things,
I mean, one thing that I think is really interesting about the conversation as a whole is, this is all based on laws, right? Which are written by legislators who are elected officials, right? And I just always wonder if the general public understands what inpatient psychiatric hospitalization is. Like, what happens on inpatients? What is the process like? Who gets hospitalized, who doesn't, and what happens during that, in particularly in involuntary situations? Like, what happens there? And I think this question of, is it effective, is very important in informing sort of like the whole kind of the ideas we have around, not just from like a medical perspective, but also around sort of like a public policy perspective as well.
Fantastic point. And of course, there's a spectrum. There are people who are, very, very familiar with involuntary hospitalization, people who are advocates who go to, policymakers, and whether for or against, there are people who have never heard of it. And then I think your point's important is, what is public understanding of these policies when we don't even know how many people are being placed on these holds? And if we think about how does that affect from a public health standpoint, for example, 988 rolling out, How many people are out there who are not calling that phone number because they don't know where that leads, right? They're afraid, they've heard of quote unquote involuntary hospitalization. And if I call this number, is someone going to kick in my door and, drag me into a hospital setting? That's a really scary thing for someone to think about, right? And I'll take the other standpoint, which is I've been fortunate. I've given some talks at law schools where you come in and the law students there who, as you mentioned, these are the people who are often going to be designing these policies, right? They're going to be becoming policymakers, legislators, lawyers. And there's such a different perspective, in many ways good, from clinicians, where our focus is safety of the patient, safety of the public, like what can we do to help this person, right? And from many of the law students' perspectives is deprivation of liberty, right? And they're very intense on that. And so what I'll often do in these talks is I'll walk through the basic decision-making that happens in an emergency department, which is somebody walks in and says, when I leave here, I'm going to kill myself. What do you do with that person? And often some students will say, well, give them medication. So they don't say that. And I say, those don't really exist. Like maybe ketamine and stuff is coming out, but like that often does not exist or is not an option, or the person still says they're going to harm themselves. Like, what do you do? And so you lead them down the pathway where often a lot of these laws are really developed out of necessity of like, what do you do in that situation? And I think that's a really great point about not necessarily like public messaging, but again, just a reflection of the lack of public data or awareness of one of the most important, in my view, policies that we have from a mental health system standpoint that a lot of people don't know about. They don't know how it works. They don't know how it functions. And how should we as psychiatrists be participating in that, whether it's collecting data, writing about it, advocacy, working with legislatures? I think that's a great point you bring up.
So just for the listeners, this article is an open forum, and an open forum is kind of like a conceptual scholarly essay. And I love these, and yours is so coherent and well argued. And again, that one of your main points is that there needs to be, if not research, there needs to be empirical investigation so that we can make evidence-based decisions. So what's the first thing? You've been in this space. How are we going to do it? You're in California. How should the various psychiatric organizations, clinical, forensic, whatever, what should we be advocating for? How can we do it? How can we get there and get out of the gate?
One thing we had talked about earlier is really the lack of awareness or even just basic understanding of how this system functions, right? And I'm kind of a pretty big advocate that we can't design solutions to problems that we don't understand, right? And so at a minimum, if I were to say one thing that I think clinicians, psychiatric organizations, medical organizations should be advocating for is really public tracking of these policies, right? These policies, to many people, as kind of Josh brought up earlier, are, whether we like it or not, are often the face of psychiatric care, of mental health services.
So what does public tracking mean? What does that mean?
So in my view, basically every state across the country, and ideally with kind of federal coordination of this, should be tracking how often are these holds happening, how long are they occurring for, how many people are placed on them. We need to, if we have laws that are authorizing, locking people in hospital units for treatment, which in many ways, again, I find can be often life-saving, how is that being used?
So who should be in charge of that tracking? So if is it a governmental responsibility?
Sure.
Should someone, should some person or agency in the federal government be tracking all of these activities at the state level?
Yeah, so one potential comparison you could make is, as I was mentioning earlier with jails and prisons, the Bureau of Justice Statistics, right? There are jails and prisons across the country that's incredibly complicated to monitor how many people are behind bars. But they're able to at least, and I'm not saying their estimates are perfect, but they're able to come up with national estimates of how many people are behind bars, age, charges they face, ethnicity. And I do think we should have something similar to that across the United States to better understand our system of civil commitment.
Thanks.
So we've got all of our state and federal agencies getting ready to go.
Well, I mean,
Okay.
come on.
Yeah.
Now, this is the main point. This is your marching orders, so to speak, right? I mean, how can we manage this if we don't even know anything about the practice across this country?
And I love your point of thinking, well, how does this practically happen, right? Because one of my favorite things I once read was, it's very easy to write in an academic essay 2 words: policymakers should. But the question is, who's reading that, right? Who's doing that? And really, at the end of the day, you're bringing up fantastic points of like on the ground, logistically, what does that look like, right? And so, yes, I do think that every state, if they're authorizing these policies, should have a central agency that is collecting data. Basically, anytime these are filed, that should be going to that central agency. And then there should be federal coordination that's monitoring across states. That, in my view, would be an ideal way to start the process where we at least understand how often is this occurring, right? And there's so much other stuff that we could look into that we've talked about today.
And then from there, we can start to understand, make change, perhaps even do research, try to understand what works and what doesn't.
Absolutely, yeah.
Well, that's probably a good place to stop. Thank you so much for joining us. Fantastic conversation. And, I think it's as you said here and said in the paper, it's a controversial topic, but I think that you present it both very even-handedly and also in a way that everybody should want to at least understand where we are right now, right? Like, we're not going to be able to make any good decisions without doing that. So thank you so much. We really encourage everyone to read the article. We look forward to hearing how your coordination of all the states and federal agencies in the next couple of weeks.
My co-author, Rob, he'll be the one doing that. So yeah.
Perfect. Great. Well, we'll have him on in a couple of weeks to hear how it goes.
Yeah, it's great. Thank you so much.
Thanks for having me.
That's it for today. We invite you to visit our website, ps.psychiatryonline.org, to read the article we discussed in this episode, as well as other great research. We also welcome your feedback. Please email us at psjournal@psych.org. I'm Lisa Dixon.
I'm Josh Berezin.
Thank you for listening. We'll talk with you next time.
The views and opinions expressed in this podcast are those of the individual speakers only and do not necessarily represent the views of the American Psychiatric Association. The content of this podcast is provided for general information purposes only and does not offer medical or any other type of professional advice. If you're having a medical emergency, please contact your local emergency response number.